Hello, Dr. Ola.
So
Yeah, we have
can
about 13 people on now.
can we start or should wait a bit?
So let's start. Let's start, please.
Okay. Okay. I hope I'm audible and you can see my slide.
Yes.
Okay. Good afternoon, everybody. I welcome you to today's clinical conference, and today I will be starting a series which I intend to continue in the next time I'm presenting, and I'll be talking about the connection between the heart and other systems in the body. That, as we know, that systemic systemic disease can also present with cardiac symptoms, so that we'll be able to open up our minds and think just beyond the heart when we have symptoms that are commonly seen in heart conditions, so that we won't think that every symptoms of chest pain, difficulty with breathing has to be just hypertension, just heart failure alone. But there are many extracardiac organs that can present with symptoms referable to the heart. And today, I'll be starting by talking about the heart manifestation in patients with rheumatoid arthritis. And that is where I will be starting. And I'll be discussing be taking us through what rheumatoid arthritis is, and I will try to talk about the connection, why patients with rheumatoid arthritis, why they present with some heart manifestation. And starting with rheumatoid arthritis is the commonest of the systemic autoimmune disease that we know. And one of the reasons why I'm starting with this is, we're just coming from our Masters of Medicine conference, where we talk about uh, the women health and as related to cardiology. And we're talking about rheumatoid arthritis, where we're talking about a condition that is commoner in women. We have ratio of 3 women to a man when we're talking about rheumatoid arthritis, and with a global prevalence of 0.5% to 1% of the population. And another reason why I'm also looking at this is we're talking about a disease condition that is common in young women between the age of 30 to 50, and you see them coming up with joint affectation, and sometimes the cardiac manifestation may even be the initial presentation in this group of patients. So I'm painting a picture of a middle-aged lady presenting with features suggestive of coronary artery disease, where you are not expecting or where you are not expecting an heterogenic coronary artery disease in that age group. And you are seeing that same lady with some joint complaints, with all this manifestation, then you should cast your mind out that this is not just only due to maybe an atherosclerotic coronary artery disease, but you should also think of casting your net wide and doing investigation that may be the revealer or the opener of other systemic affectation that the patient may be having. So rheumatoid arthritis is common in women, like I said, and we're talking about a patient presenting with symmetric polyarthritis with predilection for the small joints of the hand and feet. And going by the American Rheumatic Association, the diagnostic criteria, we're talking about patients having morning stiffness lasting at least 1 hour for 6 weeks or more, arthritis of 3 or more joints for about 6 weeks or more. I talked about arthritis of the small joint in the hand for 6 weeks and is symmetrical. Then the presence of rheumatoid nodule and presence of rheumatic factor, and coupled with radiographic changes on X-ray. So once you have 4 out of these 7 criteria, then you can confidently say that the patient has rheumatoid arthritis. And this is just showing a picture of what we have. I know we are familiar with this, the ulnar definition of the joint, swan neck deformity, botonia deformity, the rheumatoid nodule, where you can see on the extensor surfaces and the changes in the synovial membrane of the joints. And this is just showing us the broad overview of what happened in patients with rheumatoid arthritis. Is an interplay of genetic susceptibility and changes in the environment. Some people have talked about some infection, gum infection. Some people have talked about increased risk in people, in smokers, and all this with alteration in gene leads to rheumatoid arthritis. And if you remember our immunology, that we have what we called cellular tolerance. That means ability of our body to protect us from our own cells, so that the T cells, the B cells, our immunity is not attacking ourselves. But due to all these changes, some environmental factor, some genetic predisposition, there's loss of tolerance. And so what we find now is there's loss of tolerance, both the central and the peripheral tolerance system, and now you have the cells fighting themselves. So you have all those inflammatory reactions going on in the joints, damaging the joints, and could as well, this inflammatory condition can also affect some extra articular organ, and one of it is the heart that we're talking about. So you have the joint damage, and you can now have those extra articular manifestation. And like I said earlier, the longer the duration of these diseases, then the higher the chance of having all this cardiovascular disease. And now talking about the epidemiology of cardiovascular events in rheumatoid arthritis, studies have shown that almost 50% of death can be attributed to cardiovascular condition. And another thing here is it's without rheumatoid arthritis. So let's assume a patient with rheumatoid arthritis, we have a myocardial infarction at the age of 60. So what we're saying that by 40 years, the same thing can happen in a patient with rheumatoid arthritis. And this risk factor is independent of the traditional cardiovascular risk factor. As we will see later, the conventional cardiovascular risk factors are common in patients with rheumatoid arthritis, but they on their own alone cannot explain the reason why patients with rheumatoid arthritis have increased risk of developing coronary artery disease, of developing peripheral arterial disease, of developing stroke. So when we're looking at rheumatoid arthritis and the heart disease in them, we can classify them largely into 2 groups. We have the ischemic and the non-ischemic. The ischemic has to do with affectation of the coronary arteries, because what we find in them is we have what we call a premature and accelerated atherosclerosis. We'll discuss this one shortly. So there is endothelial dysfunction, atherosclerosis, and development of a vulnerable plaque, which down the line leads to myocardial infarction, leads to heart failure, cardiogenic shock, and the likes. Then we have the non-ischemic heart disease, which is mainly due to inflammation affecting either the pericardium, the myocardium, inflammation affecting the conduction pathway, giving rise to myocarditis, heart failure, cardiomyopathy, arrhythmia, and sudden cardiac death. So that is the broad classification. And it's also splitted into the asymptomatic, because studies have shown that more than 60% of cardiac affectation in patients with rheumatoid arthritis are initially silent. They only become pronounced at a very advanced stage. So some of them are just an accidental finding. Maybe echo is done for something else, and you see someone with a pericardial effusion, and you are trying to probe, you check ASR and CRP, you find that they are elevated, then from there you can now start seeing. And this is also another diagram just bringing everything together, that like I said, that the presence of traditional risk factor is there, but alone cannot explain why you have most of the complications you see in patients with rheumatoid arthritis. So it's a combination of the traditional risk factors, inflammation, both systemic and local, now leading to the complication. Like I said, you have the accelerated atherosclerosis, you can have inflammation of the pericardium, of the myocardium, and all this now leading to all those complications where you have different type of arrhythmia. You can have heart failure, whether diastolic dysfunction, systolic dysfunction, cardiomyopathy, and ultimately leading to heart failure. So let me start from the accelerated atherosclerosis. What we have found out here is because of the pro-inflammatory products that are produced in patients with rheumatoid arthritis, these pro-inflammatory cytokines lead to endothelial damage. Then with that, they also increase the production of chemokines, adhesive molecules, which further down the line attract leukocytes and other cells, leading to atherosclerosis and formation of unstable plaque. So this is the main basis of what you find in patients with rheumatoid arthritis. So you have the tumor necrosis factor, alpha, interleukin-1, interleukin-6. Then you have the helper T cell producing the interferon gamma and interleukin-17, all this. So leading to endothelial damage, smooth muscle cell activation, and macrophage activation. So leading to formation of atherosclerotic plaque. And these kind of cytokines, also apart from working on the endothelial cell, they also work on the smooth muscle, the adipose tissue, and leading to other problems, insulin resistance, dyslipidemia, apart from the traditional presence of problem with lipid, maybe obesity, and also works on the liver to produce all these thrombotic materials. So further worsening the atherosclerosis and obstruction you have in patients with rheumatoid arthritis. So this is the baseline and the basis, and this is why the treatment is targeted at blocking some of these cytokines. So you have the TNF alpha inhibitor, so that we can break the inflammatory cycle that is going on both in the joint and in the blood vessel and on the other organ. So we have both macro and micro circulation problem in patients with rheumatoid artery disease. And like I said, most of these patients have silent asymptomatic disease. So most of them, it is unrecognized until it is advanced, when most of them start presenting with heart failure, with fatal arrhythmia, and that is when you get to see some of these changes that has been happening in the background. And studies have shown that the risk of developing myocardial infarction, coronary artery disease in patients with rheumatoid arthritis is similar to what you find in patients with diabetes mellitus. So the same way we treat patients with diabetes mellitus with very high index of suspicion, we want to check the lipid, we want to look at the troponin, we want to check the same way we should treat patients with rheumatoid arthritis. Because like I said, when I talked about the classification of the condition, most of the conditions are initially asymptomatic. They don't present with symptoms. They don't have any chest pain, but somebody is just coming down with unexplained heart failure, unexplained dyspnea, unexplained cardiogenic shock. Something might have been going on. And like I said, this thing also occur earlier, like 10 years earlier than in people without rheumatoid arthritis. And coupled with that, the long-term outcome is also worse in patients with rheumatoid arthritis. Then, going on to the next one, looking at the myocardium. The same local inflammatory process can also occur in the myocardium. So you have all these changes going on, remodeling of the muscles and leading to myocardial fibrosis. So this now leads, if the conduction system is affected, you can have patients presenting with fatal arrhythmia. You can have patients coming down with myocarditis and heart failure. So when you see in young middle-aged woman presenting with unexplained heart failure, your mind should go to myocarditis, and you also should think of autoimmune disease in the form of rheumatoid arthritis and SLE like that. And in these patients, what gives it out most of the time is you do, for one reason or the other, patient has to do an echo and you see a young person with a dilated cardiomyopathy, diastolic or systolic function, and you should then raise your antenna and look for other things. And like I said, the mortality in them once they develop heart failure is worse than the same age group patients without rheumatoid arthritis, despite the fact that their cardiac function might be better, their blood pressure might not be as high as other, but for the fact that there is associated rheumatoid arthritis, their long-term outcome is very, very poor. Then, the pericardium is also not left out. Actually, pericarditis is the most common presentation, is the most common cardiac presentation in patients with rheumatoid arthritis, and is also as the inflammatory process as the underlying pathology. So in this patient, what you have for most of them is you see them with pericardial effusion or thickening of the pericardium when you do an echo or other tests like that. So, but most of the time, like I said, like the other, most time it is asymptomatic, but you have very few percentage where they can have massive pericardial effusion with development of cardiac tamponade, and some of them might actually have constrictive pericarditis that may require extensive management. But significantly, most of them are asymptomatic, and the few ones that will be symptomatic are mostly male, and the ones that have rheumatoid factor, positive rheumatoid factor, and those ones that have longer exposure to the disease where the diagnosis is more than 10 years, then these are the ones that have clinically significant pericarditis, but in more than 60%, it is asymptomatic and the effusion will resolve spontaneously without any intervention. But for some, we might need to use steroid, colchicine, and the 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 drugs, the DMARDs for them, as the case may be. Then going inward, so the valves can also be involved in patients with rheumatoid arthritis. Valvular affectation is not very common, but in patients that have rheumatic nodule, inflammation too can also affect the valve, leading to thickening of the valve. And mitral valve is the commonest valve that is affected. And what you see most of the time is asymptomatic mitral regurgitation. And you can also see mitral prolapse. But like I said, they are mostly not significant, not major regurgitation, and no specific treatment is actually needed. But in very, very few cases, you can have significant mitral regurgitation that may need surgical review and surgical intervention. But in most people, it's typically mild, trivial, asymptomatic mitral regurgitation, and aortic valve is next after mitral valve. And we'll see as we put it together that most of these complications are common in patients that have severe disease, patients that are rheumatic factor positive, and patients that have longer exposure or longer duration of disease. Then, in patients with, as part of the inflammatory process going on, or in some patients, you can have deposition of amyloid or the nodule forming along the conduction pathway. So they can also present with different type of arrhythmia, both brady and tachyarrhythmia you can have in patients with rheumatoid arthritis. So you can have different type of block, you can have ventricular arrhythmia, you can have atrial fibrillation, you can see different type of conduction abnormality. Then another thing, the accelerated and premature atherosclerosis that leads to coronary artery disease can also be the underlying cause of arrhythmia in this group of patients. So all these things are things that you can see in them, and so it is for us to be on the lookout for this. So you, like I said, the picture of the patient you'll be expecting a younger patient, female, now coming up with all these presentations. So you will need to do your findings, take your history, check them, do your blood test, do your x-ray, look at the joint, and be able to make your appropriate diagnosis. Then the pulmonary circulation can also be affected, and patient can actually present with pulmonary arterial hypertension, but this is commoner when you have coexisting underlying lung disease or other issue. But like I said, there could also be inflammation affecting the pulmonary arteries, leading to pulmonary hypertension. And what we give this away is patient presents with dyspnea that you cannot explain. But this may be difficult to identify early because, like I said, the pulmonary arterial hypertension is commoner when there is coexisting lung disease or patient has chronic thromboembolic pulmonary embolism. So that may make it difficult for us to be able to find that out. But echo, doing a CT-PA can help you to identify and to be able to separate each condition from each other. But we should have it in mind that rheumatoid arthritis can also present with pulmonary arterial hypertension. Then another connection between rheumatoid arthritis and the heart is the medication that is used. Because we should not forget that these are patients that will be on long-term use of corticosteroid, on long-term use of disease-modifying anti-rheumatic drugs, and some of these drugs, as they are helping, they can also affect the heart in another way. Number one is, if we look at the use of hydroxychloroquine in this group of patients, is one of the drugs that helps in their management, but in some patients, the hydroxychloroquine can also induce cardiomyopathy. So what you are seeing may be the effect of medication and may not just be due to maybe underlying atherosclerosis or inflammatory changes. Another drug that is also used in the treatment is methotrexate, but it has also been found that methotrexate also increases the production of homocysteine, and as we know that homocysteine is also a cardiovascular risk factor, a proatherogenic cardiovascular risk factor. So, but all these drugs are good, but long-term, prolonged use of this drug in this patient can also lead to some cardiovascular manifestation. Another drug that is used is leflunomide, which can also lead to hypertension. So as good as it is, reducing the rate of MI and all the rest, for patients with hypertension, and like we know, they are taking steroids, which can make them to have elevated blood pressure. There are long-term non-steroidal anti-inflammatory drugs which can also affect their blood pressure. So this is another drug now that can also aggravate hypertension. So we need to weigh a lot of things, and that's why when we're seeing our patients, taking drug history comes into play here. So you need to know the drug, and you need to know the interaction and the effect of the medication on the patients that you are seeing. Then, like I said, these patients are also on corticosteroid and non-steroidal anti-inflammatory drugs. So you have patients that we're talking about taking corticosteroid, and we know the long-term side effect of corticosteroid, and many of them are even on a very high dose of this steroid. So you have the blood pressure issue, the blood sugar issue, the weight, and every other thing, wound healing, skin changes, and all of this. So this on their own too increase their risk of cardiovascular events. But the big question is, these changes or all this effect of drug that we're talking about on the heart, are this problem, are they due to the disease activity or the atherogenic potential of this medication? Because most of the patients that will be on this drug, they have high disease activity. The inflammatory changes going on in them is very enormous. So are this problem as a result of those high disease activity, or is it a problem of medication? These are questions that subsequent research and studies will still need to answer for us. Then, still going on the drugs, I talked about the tumor necrotic factor alpha as one of the pro-inflammatory agents responsible for the inflammatory changes going on in the blood vessels, going on in the heart muscle, in the pericardium. So using anti-TNF is one of the major treatment points in patients with rheumatoid arthritis. But it has to be used in caution with rheumatoid arthritis patient that has established failure, because when you use anti-TNF alpha medications in patients with established heart failure, that worsens cardiac function. And what was found was that TNF alpha is actually a cardioprotective agent in patients with established heart failure. So we need to be careful before our rheumatologist will start the patient on this drug. they need to take history and send the patient to cardiologist to do an echo for us to confirm what the EF is. The same way our oncologists do before they commence their patients on the medication to do a background echocardiography to know what the cardiac function is before you put your patients on the medication. And this is what I've put. This diagram is also showing us the TNF alpha antagonist and telling us that they are only beneficial in patients with rheumatoid arthritis that have preserved heart function. But in those with established heart failure, is a no-no, because it's only going to exacerbate their heart failure and increase mortality in them. So this is an important take-home point that we should put at the back of our mind. So now, what are the factors that increase the development of cardiovascular events in patients with rheumatoid arthritis? Number one, the traditional risk factors. So studies have shown that the traditional risk factors we're talking about, the age, obesity, sedentary lifestyle, inappropriate diet, smoking and hypertension are also found in them, and is even commoner in them. So their presence also is increased risk for development of cardiovascular event. But like I said earlier, their presence alone cannot explain the burden of disease we find in this group of patients. And most importantly, we want to point out smoking. Smokers have increased risk of development of cardiovascular events in rheumatoid arthritis and also hypertension. So any of these patients smoking, they have to stop smoking. They have to stop smoking. So another factor that increases cardiovascular events is the severity of the disease and presence of disability. So the more severe the disease is, the higher the chance of developing cardiovascular complication in rheumatoid arthritis. Then when the patient is rheumatoid factor positive, like we know about 70% of patients with rheumatoid arthritis have rheumatoid factor. So the presence of rheumatic factor and anti-CCCP antibodies increase the chance of development of cardiovascular complications. So when you have other extra-articular manifestation, it's also a point pointing to increased risk of cardiovascular complication. So when the patient has high ESR, high CRP, you should know that the patient has a very high level of inflammation going on, and that patient is a patient that you should be on the lookout for, trying to check, be on the lookout for development of coronary artery disease and other cardiovascular complication. And we have a paradox here. It's been found that rheumatoid arthritis patients with low weight has higher cardiovascular events. As we know, for conventional risk factors, what we know is obesity increases the development of cardiovascular complication. But in patients with rheumatoid arthritis, low BMI has actually been found to be a risk factor for development of cardiovascular disease. So what do we need to do for these patients? Number one, we have to aggressively manage all our cardiovascular risk factor. Because like I said, the risk of development of ischemic heart disease in patients with rheumatoid factor is the same like we have in patients with diabetes mellitus. So the aggression we used in pursuing patients with diabetes mellitus, looking at their lipid, checking all the other cardiovascular risk factor, is the same strength we should use in managing the risk or the cardiovascular risk factor in patients with rheumatoid arthritis. So increased level of physical activity. We know this might be difficult because of all the joint affectation, but if they cannot do active activity, passive physiotherapy, physical activity physiotherapy can be done. Like I said, smoking cessation, good diet, blood pressure control using the conventional standard medication should be done for this patient. Their management is not just only disease-modifying anti-rheumatic drugs alone and aspirin, but their cardiovascular risk factor must be aggressively managed. Then use of statin in them is very, very essential. And in them, the use of statin goes beyond controlling the lipid level, because statin has also been found to have anti-inflammatory action, and studies have shown reduced level of ESR and CRP in patients taking statin. So for this group of patients, they need to take statin to manage their lipid level, and also because of its anti-inflammatory properties. And like we said, that inflammation is the key underlying pathogenesis in the development of most of the cardiovascular complications we have in this group of patients. So I talked about management of blood pressure and DM, so the use of our conventional drug, our ACE inhibitor, angiotensin receptor blockers, our beta blockers, all of them should be used based on the presence of this clinical condition. Then judicious and cautious use of our corticosteroid and NSAID, like I said, we talked about the complication that can come from them, but many of them, especially those with high burden of disease, still needs to be on this medication. Those with pericarditis, myocarditis, they need steroid. So it should be used with caution and it should be monitored. Then the use of the disease-modifying anti-rheumatic drugs, the different group, they must be used, because like we said, the longer the disease duration, the higher the risk of development of cardiovascular disease. So you want to start this patient on this medication and control the disease progression as early as possible. So now that we've talked about inflammation as the underlying pathogenesis leading to premature atherosclerosis and changes in the blood vessel, some people have advocated screening of patients with rheumatoid arthritis to check their carotid level, to check the intima thickness, or do calcium scoring to be able to identify patients with coronary artery disease on time. Some people have done this, but it's not been accepted as a conventional screening. So it is not recommended that screening should be done. Maybe calcium screening, CT angiography, Doppler ultrasound of the carotid has not been conventionally approved as a widespread screening method for this group of patients. So, but what we need to do is aggressive management of risk factors using all the things we need to do: lifestyle modification, use of statin, controlling the BP, and the use of the medication that is indicated in this group of patients. So, putting everything together, rheumatoid arthritis is the most common autoimmune patient disease condition, like I said. And this group of patients, they suffer significant morbidity and mortality from cardiovascular disease. Like we said, half of them will die from cardiovascular condition. And the risk, like we said, is the same as in patients with diabetes mellitus. So telling us that we need to be aggressive with them. We need to manage them the same way we manage patients with diabetes mellitus when it comes to cardiovascular complication. So aggressive medical therapy, aggressive control of cardiovascular risk factor is advocated in them, and we should be proactive when we see these patients, when they present with us, when we see them having all these extra articular manifestations. We should also take time to look at their heart, let them do an ECG to rule out arrhythmia, to see whether they have things on the ECG that may suggest ischemic disease. If they need to do echo to rule out pericarditis, to rule out heart failure, because like we said, most of these events, for most of the time, they are asymptomatic. You only see them when they have gone to the advanced stage. So this is the end of my presentation, and these are my references. Thank you for listening. So if we have questions and comments, now is the time to ask and make that comment. So comments and questions. Comments and questions. So like I said, it's going to be a series, and we're going to be looking at different systems and talking about their connection to the cardiovascular system. So we should not forget to send our mail address so that you can get our CME. Okay, somebody is raising his hand. Ivan Vika. I think you can speak if you have a comment, sir.
Good afternoon. It's a question that I'd like to ask.
Okay.
Well, thank you for the presentation, but I'd like to know if there's any local study at HIC or anywhere that on this topic.
Local study, not yet. We don't have one in HIC, and actually, I didn't even see anyone locally that I would have added in this presentation, and that's why I said it's an area that is open to a lot of work. We need to see, at least locally, the prevalence of cardiovascular condition in this group of patients. We need to see the effect of drug they are using, whether it's the drug that is responsible for what we're seeing, or maybe the disease condition. So is an area where there's a lot of work, and there's an area that is called cardiorheumatology area. I saw that as I was preparing for this presentation. So is a good place for us to work on and see the prevalence of cardiovascular condition in patients with rheumatoid arthritis and other autoimmune disease.
Thank you.
So Dr. Lalikan, thank you. Excellent presentation. I kind of have like a double barrel question where I kind of want to point in some direction to see what your thoughts are. These conditions that you have well described, and its effect on the cardiovascular system. Do you know one of the things that GLP-1 receptor agonists have been great modulators of a lot of things? Do you see any data on its impact on these conditions? That's one. The second question, maybe I missed it. I don't know if you had any discussion on genetic predispositions, whether these conditions are more common in ethnic African populations, or whether there are more predilection for cardiovascular involvement in patients with ethnic African background, like Caribbean patients.
Okay. Thank you very much, sir. At the beginning, when I made a small talk on the general pathogenesis of rheumatoid arthritis, one of the factors that has been talked on is we have genetic predilection in terms of some HLA predilection. But like I said, that there is actually paucity of work from Black population. There was no main mention of Blacks being more predisposed genetically to development of rheumatoid arthritis or cardiovascular complication when compared to the Caucasian. Most of the studies compare patients with rheumatoid arthritis and without rheumatoid arthritis. So that's why I said is an area where a lot of opportunity is to find out many of these things. Because also when we're talking, amyloidosis has been identified as a major cause of both the arrhythmia and heart failure in them, which is also what we're working out to find out how prevalent is in Black. So there's a lot of opportunities and work that needs to be done here to now see, okay, we have this. Now, looking at the Black, what is the prevalence of even the rheumatoid arthritis as relates to Black, and what is the prevalence of cardiovascular condition, and whether there is any genetic predisposition that make Black to be more susceptible or to be more predisposed to development of cardiovascular complication when they have rheumatoid arthritis. Then as relates to GLP, in all the papers that I checked, I actually didn't see any specific mention of GLP as it relates to improvement of as in reducing the risk of cardiovascular events in patients with rheumatoid arthritis. But looking at it generally, I think I've checked that GLP has been found to help in articular disease, in osteoarthritis, but specifically in rheumatoid arthritis, I'm not sure if I've seen that, but I think if it works in patients with diabetes, it may, because insulin resistance is also one of the factors that the pro-inflammatory cytokines elicit in patients with rheumatoid arthritis. I think it may also be useful in them, but I'm not very sure.
Okay, thank you.
So, other questions and comments? Any other question and comments before we call it a day? Okay, there's no question in the chat box. So let me appreciate us again for giving us your time to be part of this conference today. So next week, Thursday, will be another time for the conference, and the topic will be shared by Monday or Tuesday so that we can prepare for that. And like I said, let's send our email as directed so that you can get our CME. Thank you for joining us today, and see you next week. Bye-bye.
Thank you.